talk about this amylin story. So in previous talk, if you remember earlier this year, Leon talked about Novo Nordisk have this CagriSema combination of an amylin receptor agonist with a semaglutide in one drug and one injection, and get very disappointing news because the Wall Street expect more average percentage weight reduction, causing Novo Nordisk's the stock price drop, losing the kind of capital market cap of a whole Regeneron in one day. That's how crazy this obesity space is. People, the expectation has been raised. That's why it's now fascinating to talk about GLP-1, GIP now having amylin come into picture. When I give the Chinese webinar for Nobel Prize in 2024, predictive in 2024, I mainly focus on GLP-1 as the main discovery story. I mentioned a little bit about GIP. I didn't have time to talk about amylin. And it turns out amylin is a very fascinating hormone on top of the incretins. When we talk about incretins, GLP-1 and the GIP, which you already covered, and amylin turned out to be secreted by the same cell as insulin. So the beta islet cell in the pancreas secrete both insulin and amylin. The molecular ratio can change. Some people say 10 molecule of insulin to 1 molecule of amylin can be 15 to 1, can up to 101 because it's not difficult to measure the exact ratio. But the reason amylin was discovered much later, people know in 1921, insulin was discovered. In 1923, they got a Nobel Prize. The insulin was discovered so much earlier, not only because of the ratio. Another thing is because amylin is very similar to GLP-1, GIP. It's a polypeptide, shorter peptide compared to insulin, 2 chains, and also easy to form, as the name suggests, amyloid, which is circle back to the previous story. Amyloid is just such a fascinating form of protein aggregates, occurs in so many different places. In the case of amylin, they discover in the diabetic patients in their pancreas, they see those protein aggregates. Then they were able to discover amylin as a hormone co-secreted with insulin. So it turns out that GLP-1, GIP, amylin have similar regulation, but they are different because GLP-1 and GIP are coming from the GI tract at different cells, L cell and M cell in the intestine. But amylin comes from pancreas. So that's why the whole business about GI, the gut, brain, pancreas, this triangle, multiple axes in the regulation of food intake and blood glucose turned out to be very fascinating. That's why I don't know if we have time to go all the deep, but just suffice to say, amylin was discovered pretty late, 1987, because of this easiness to form aggregates, making it less soluble. It's also difficult to identify in terms of amount in circulating blood in amylin, also pretty low. So that's why, but it turns out the story is very interesting. It also have brain effect in terms of reducing food intake, and it also can suppress blood glucose. So it can be a anti-diabetic drug. So circulating amylin can have effect on many different organ systems as long as you have the amylin receptor. It turns out the receptor biology for amylin is way more complicated than GLP-1 and GIP. That's the reason why so far there's only one amylin receptor agonist drug approved in 2007 by AstraZeneca. It takes almost 15 years still waiting to be approved because the receptor biology is so complicated. I'll explain later. But overall, it's a peptide with 37 amino acids. People recall GLP-1, human GLP-1, initially have 37 amino acids, but amino acid 1 to 6 need to be cleared off. So the active form is 7 to 37, 31 amino acid. But amylin, the 37 already fully function. So that's why it's a very interesting hormone to go a little bit deeper. The main take-home story is that it belongs to a family, calcitonin. So that's also really interesting. People know calcitonin is a hormone based on name. Tonin means it reduces the blood calcium concentration. It regulates mineral kind of concentration. And then there's a fascinating family of protein, CGRP, and it stands for calcitonin gene-related protein. And multiple forms, there is alpha and beta, but they also have this kind of interesting involvement in the pain medication. There's some painkiller approved for the targeting CGRP. That's another fascinating story. But amylin, interesting, belong to the same family. It's belong to the calcium regulating family. It also belong to the same family as CGRP. So that's already fascinating. And the sequence homology is pretty low, but some key residue are conserved, so that the protein fold overall is kind of have some similarity. People can try AlphaFold too, to just saying why such a low sequence homology can have this belong to the same family. That's another story. But overall, the receptor biology is so messy because it has receptor and co-receptor. So the main receptor is the calcitonin receptor, GPCR. It's the class B GPCR, 7 transmembrane domain. And but interesting, calcitonin only needs this GPCR. That's it. It's called CTR, calcitonin receptor. It turns out amylin, just this GPCR is not enough. It needs a partner, binding partner, called the RAMP, receptor activated membrane protein 1, 2, 3. And in some case, in the case of CLR, this like the other, like adrenomedullin 1 and 2, this binding protein serve as molecular chaperone. That's another story I shared earlier. Some family member need this chaperone to move it to the membrane, plasma membrane, to get to a cell surface. But in the case of amylin, they don't need the RAMP 1, 2, 3 to be the chaperone, but it needs as a binding partner to dictate the specificity. So that's why amylin as a ligand, having 3 different receptors. It's not shown on this graph as on this diagram. AMY1, AMY2, and AMY3. And here you can see CLR. There's a related protein related to CTR. When CLR bind to RAMP 1 and 2 and 3, it have different ligand. CGRP, adrenomedullin 1 and 2. But when you have the CTR, the calcitonin receptor, partner with RAMP 1 and 2 and 3, you get AMY1 and AMY2 and AMY3. So it's a very messy situation. The antibody is not very specific to tease out 1, 2, 3, become a major challenge. But the whole field, after 1987, they have to struggle. Then you do knockout mice for RAMP 1, 2, 3. Turn out RAMP 2 is embryonic nasal, so they don't know whether RAMP 2 is involved at all. It was weight control, but at least they show RAMP 1, that means AMY1, is involved in weight control. AMY3, a little bit, also weight control. That's why Eli Lilly's compound mainly target AMY1, meaning RAMP 1 partner with the calcitonin receptor CTR. And it's interesting history. The AstraZeneca, for whatever reason, always the pioneer. People remember in the breast cancer field, fulvestrant is the first ever SERD ever getting approved. And in 2002, way more ahead of other people, but it's a pain to have to inject. The PK property is not good, but they're pioneer in 2002. Today is still one of the standard of care for certain type of breast cancer, for fulvestrant, AstraZeneca invention. Then in 2007, before the GLP-1 field even become catching people's attention, AstraZeneca was acquiring some company or invented by themselves. They identify this kind of natural occurring kind of peptide, very similar to the human amylin, called pramlintide. And pramlintide, having a lot of kind of amino acid difference, it turned out to be druggable, developed as a drug, and approved by FDA in 2007, not for obesity, for diabetes. Because 2007, nobody was thinking about using hormone-based therapy for that obesity yet. It's mainly for type 1 diabetes, type 2, but it's a supplementary to insulin. That's why it's a great pioneer. That's why we have to say this is a milestone in the history of amylin mimetics. AstraZeneca is a pioneer. Then after so many years, we still don't have another approved. If you don't count salmon calcitonin, I don't know if people know about salmon. Is that a dietary supplement? Salmon, when you eat salmon, can potentially reduce glucose? I don't know. People can tell me why salmon calcitonin was also approved by FDA in the same family. But now, as GLP-1 taking off, this field getting very hot. Amylin recatch people's attention, but because of the complex receptor biology is a mess. it takes so many years to figure out the PK property about which receptor. It's still not easy. That's why it takes so much longer compared to GLP-1 receptor agonist, compared to GIPR agonist. They can see here in the kind of flow chart, after 2007 approval for AstraZeneca Plamlinide, there's some in phase 3, including CagriSema, and Eli Lilly's compound that we will introduce today is pretty much phase 2, going to go into phase 3. Then you saw the news by Novo Nordisk have this oral amycretin, is an oral amylin receptor agonist, also maybe entering phase 2, or wrapping up phase 2, entering phase 3. So this field now become very crowded. Then what's unique about Eli Lilly? This is not oral amylin receptor agonist. This is injectable. But they did similar engineering as Novo Nordisk with GLP-1. They modified the 37 amino acid sequence using some gamma linkage. And some of them, they changing certain amino acid to avoid this aggregation problem. Remember, the wild type amylin is very easy to have multimer and oligomer. Then it's very easy to form insoluble amyloid kind of structure. That's why making a druggable amylin drug using natural amylin won't work, because once you increase concentrations, it will become insoluble. That's why they have to engineer the protein sequence, introducing as well the fatty acid chains, like Dr. Knudsen did with Novo Nordisk, to bind to albumin reversibly so that it can increase the plasma half-life. So this, after some engineering, they were able to achieve weekly injection. This is subcutaneous injection by doing the very good engineering. And they also show that it has 12-fold greater potency than the natural ligand. That's also very good in terms of efficacy. Then in the phase 1 studies, they already show the weight reduction even at 12 weeks after weekly injection. They can achieve dose-dependent weight loss up to about 11.3%, no plateau for all those groups. That's very encouraging. That's why they quickly move into phase 2. And phase 2, now they really do a dose escalation. Make sure they figure out the best dose, 1 milligram, 3 milligram, 6 milligram, 9 milligram, all weekly injection. Then, yeah, it's very a little bit sophisticated, 2 to 1 to 1, yeah, all kind of dose group randomization. Then, of course, they still need to evaluate safety. The 12 weeks was not long enough. And this is a 48-week study. The primary endpoint is 48 weeks, quadruple the original 12 weeks, then to see if the weight reduction can still keep showing up. They have some exclusion criteria I won't touch, but mainly excluding type 2 diabetes patients from the trial and the pancreatitis. And then they do specify what's the primary and the multiple secondary endpoints. Primary endpoint compared to other trial, of course, is a percentage change in weight loss from baseline at 48 weeks compared to placebo. Then they included some additional secondary endpoint. And in terms of efficacy analysis, I want people really, for BioSpark member, you can go back to watch Wei Wang's sharing also on WeChat channel about efficacy estimate. That's a very exciting talk when Wei shared with us. So here, for earlier phase 1 or 2, they can use the efficacy estimate to just assuming all the patients comply. And it's because some patients will be intolerable. When you're using an efficacy estimate, you can somehow overestimate a little bit. But eventually, for registration trial, you have to do the so-called treatment policy estimate rather than the efficacy estimate. That's the interesting detail going back to August. Then quickly, its safety profile looks pretty good. And Eli Lilly, this data set is very comprehensive. They have all the efficacy endpoints and detailed efficacy and the safety endpoints all published in the Lancet paper. People are encouraged to take a read. I won't go through all of them, but it's basically some GI related issue. None of them are significant, but there's blood pressure also have some change. That's something new compared to GLP-1. Usually GLP-1 population, you rarely see blood pressure, but overall that's pretty mild. Let me go to the efficacy a little bit more. In terms of the head-to-head comparison, it's not a head-to-head trial, but people pay attention to the baseline, 48 weeks, how much you can show reduction. Yeah, not surprisingly, you have a dose response curve. That's very nice. And then up to 20% in the 9 milligram dose, weekly injection, up to 20% weight loss. And it's a very nice dose response. And so the primary endpoint looks very good. So that's why Eli Lilly now, the valuation of Eli Lilly market cap is the #1 company, just above 1 trillion of market cap. Eli Lilly keep getting good news in the weight loss field. Then in terms of, and one of the second endpoint, you can count what's the percentage of patients was able to achieve weight reduction by 20% or more. Then you count the percentage, you can see the high dose group having pretty decent 57%, up to 57% of patients can achieve 20% weight loss or more. That's also very good news. Then they also want to look, one of hypotheses in the early days, people was wishfully thinking, a GLP-1, GIP-1 receptor agonist losing weight by losing muscle as well. Of course, you're mainly losing fat, but you're also losing some muscle. They were hoping maybe bringing amylin, we can lose less muscle. Turns out it's pretty much, at least based on this trial, phase 2, it's similar. Overall, you probably majority of your loss is 60 to 70% is losing fat. That's good news. But it sounds like with amylin, GLP-1, GIP, you have to lose some muscle. So that's why Regeneron is now very enthusiastic to bring the muscle-sparing weight loss kind of drug into the market. But I don't know how difficult is that. But at least you can see, even in amylin receptor agonist, about 20% or 30%, still you're losing some lean mass. That means it's not perfect drug. You still need to, dealing with the potential loss of muscle. But it's overall pretty comparable compared to GLP-1. So it's a very encouraging data set. So I'm going to wrap up here saying this is efficacy, safety, all looks pretty good. Lilly is moving very quickly into phase 3. We don't have time to talk about Novo Nordisk's amycretin. Hopefully next month or the month after, when Novo release more detailed data, we can have another discussion in the head-to-head comparison between the amylin space and, of course, amylin combined with other things. So I'm going to stop here. People are encouraged to type in the question. I'm going to stop sharing and turn over the screen to Qinghong for the final topic.